Hello to all the viewers. Today we have the pleasure of hearing the opinion about FIDA from Prof.Markus Graler from Vienna University Hospital in Germany. Hello, Markus.
Hello, thank you very much for having me.
Thanks to you for sharing your opinion. Would you tell us a little bit more about your position in Vienna University Hospital?
Yes, so I'm a professor in the Department of Anesthesiology and Intensive Care Medicine. And we are working on basic science mainly. The main topic of my research is the role of lipid signaling in sepsis. And sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to an infection. So we're interested basically in systemic infections. And the main lipid metabolite that we are interested in right now is sphingosine 1-phosphate, or S1P. And S1P is constitutively present in blood and circulation, serum, and in plasma. And it's bound to certain carrier molecules. The most important ones are serum albumin and high-density lipoproteins. This binding is important to solubilize the lipid, but also to stabilize it and to protect it from degradation. And there is recent research that is still ongoing that also suggests that the use of different carrier molecules also changes the signaling capabilities of sphingosine 1-phosphate. And this is very interesting for us. And so one of our main goals that we also want to address, or are trying to address with the FIDA technology, is the different binding capabilities of sphingosine 1-phosphate in certain pathological conditions, working with patient samples, actually.
Yeah. So how does FIDA fit and or contribute to your research? Could you develop on that?
Yeah, so FIDA is a new technology that is introduced to, or was introduced to look at intermolecular interactions. And so the idea that we had was to use this technology to look at sphingosine 1-phosphate binding to its certain carrier molecules and to differentiate between binding of S1P to serum albumin and to high-density lipoproteins, which was not so easy, but I think we got a pretty good methodology right now that enables us to do so.
So did it in the end help you to tackle the challenge?
Yes, so I think we are on a good way. So we are trying to expand this technology, of course, also for other lipids and other conditions. But so far, we are quite happy what we see with the FIDA technology.
Would you like to show us how did the data obtained through FIDA contribute to the studies that you have performed and are performing?
Yeah, sure. So I prepared some very few slides.
All the viewers can also find different publications on our website. So I think that it's good to just have a little look. And
maybe they will find this one very soon as well. So this is just released in iScience, where we have a first look at our methodology in patient samples using the FIDA technology. And so we were able to basically create different binding curves for, on the one hand, serum albumin, on the other hand, high-density lipoproteins, under different methodological conditions using the FIDA technology. And with these different methods, we were also able to separate HSA binding and HDL binding. So this is kind of the primary data that we got with these technologies. So in red, you see the indicator. We are using a fluorescently labeled sphingosine 1-phosphate, fluorescein labeled sphingosine 1-phosphate as an indicator. And when we mix it with either human serum albumin or with HDL alone, you see that the tailogram is widening, which indicates a binding of the lipid to the cognate carrier molecule. And we can apply those two methods also in a complex mixture, which is usually plasma. And these are the results with a patient cohort of surgical trauma patients, patients suffering from sepsis, and septic shock patients. As you can see, the patients are losing their binding of S1P to serum albumin. And interestingly, at the same time, they show an increased binding to high-density lipoproteins. So you see a switch of binding from one carrier to another carrier. And we think that this is also important for the pathology of these patients because this might change the signaling capabilities of sphingosine 1-phosphate in those patients. And as you can see here in the last group, the septic shock group, you have a huge diversity of complex formation with low and high complexes of HDL and sphingosine 1-phosphate. And when we analyze this group further on, we can see that the very low complex formations are mainly patients that didn't survive, and the high complex formations belong to patients that survived sepsis. And these are samples that derive from the day of admission to the intensive care unit. So at this time point, nobody would have known what fate the patient was actually facing in the clinics. And we hope that this technology can help to discriminate patients requiring more or less intensive care in the hospital.
Very impactful. Yeah, undoubtedly. Wow, congratulations on the publication and on the research. It's yesterday that it was published. Am I correct?
Yes.
Congratulations.
It was going online yesterday.
Yeah. Fantastic. Okay, wow. So you work on plasma from the patients directly. You use plasma in FIDA.
Correct. So
Yep.
we have to dilute the plasma 10 times actually, because FIDA is basically working with fluorescence detection, and plasma itself has a high autofluorescence, also mainly by the amount of serum albumin that is present in plasma, and therefore we need to reduce the amount of plasma mainly because of the background fluorescence that we are facing using samples.
But otherwise, do you find it difficult to work with unpurified samples?
It's actually very easy, and that is also something that we like with this method, because even students that have not very much experience with this technique in particular, but also with other techniques in general. So students that are just starting their career in the hospital are able to work with this machine and with this setup of FIDA. So for us, it's really a surplus that we can have many different people working on that machine, and that makes it very easy for us.
And is it impactful for you that you can use different buffers, detergents, that you have the flexibility of designing the experiments? Probably that was mainly important at the beginning before you get to build up your methods. But did it matter for you, the flexibility of changing the sample the way you wanted it?
Yes, I think that's very important, because in the beginning, we weren't really able to separate serum albumin and HDL binding of S1P. And it was therefore very important to start with very with samples with a low complexity, so samples that only had serum albumin dissolved and samples that only had high density lipoproteins dissolved, to see if we find ways to separate the specific binding of both molecules. So we started out with PBS in the beginning and dissolved molecules under these conditions. And then we continued to, in the end, work with plasma as a very complex matrix that we can use directly as the natural, kind of fluid that we get from patients.
Yeah. What about the speed? Because I'm assuming you're working with intensive care. Is it fast enough?
That's also a very important issue. So for each of the methods, we need 7 minutes to get it through. So we have two different methods, which makes it 40 minutes in total. Before we had FIDA, we had to use mass spectrometry for the analysis of the lipids, and we had to separate the different lipoproteins from serum albumin in the plasma before we could do any analysis at all. And this is very time-consuming, elaborate, technically challenging, error-prone, and it takes just a lot of time to get some few samples processed from patients. And now we are able to really focus on even large patient cohorts with a couple of hundred patients that we are able to process with the FIDA technology, and that makes it very versatile for us.
Wow. So basically just remove the whole step that you had to process your samples and then use mass spectrometry. Now you only dilute the serum and you run it in FIDA, which takes 14 minutes overall per sample. Okay. That sounds amazing. And otherwise, how does FIDA fit into the landscape of other technologies you either are using or have been using before?
Yes, so as I mentioned, we were using liquid chromatography coupled to triple quadrupole mass spectrometry before. So we have kind of a history also with this analysis technique. And that's very, for this particular issue, very time consuming because you need to do several biochemical separations before you can analyze the samples. A different other technique is fluorescence microscopy, particularly since we are also using a fluorescence labeled lipid. We used that in former times also with fluorescence microscopy, but this is more gives you more qualitative data and not quantitative data. And in this case, we are really looking for even slight differences in the patients. As you could see from my slides, you have already kind of a broad variation of individual patients regarding their binding capabilities, and only if you are able to discriminate these slight differences, you are able to create these different groups and see differences in the patient cohorts.
Yeah. So if I just because my knowledge about sepsis is limited, but do I understand it well that if this was scaled like the research you're doing now, then basically the fact that you're able to get this information on what kind of how bad how bad it is and what kind of treatment does each patient need, then the fact that you're able to do it within those 14 minutes, which of course we add the fact that you need to take the sample and whatnot, but you basically cut it from many hours into a matter of minutes. that can have a direct impact on the treatment of specific patients and their faith, basically. Do I understand it right?
Well, in the end, we hope that, of course, we hope that this technique may also contribute to the diagnosis in the clinics at a certain point. Right now, we are still in the phase of basic research, and our hope now is that we are able to find new ways also for the treatment of sepsis. Because if you tell the story or think a little further, once you know that you have a different binding of a signaling molecule that changes or modulates the signaling capabilities, you may want to switch this back to the normal situation, and that's what we are currently trying. So there are, for example, supplementation or serum supplementation is a potential treatment also in sepsis patients. And that's the next step now, to see if such supplementation procedures can switch the binding capabilities back to more S1P binding to human serum albumin, and if this is also able to switch the cellular signaling into a different direction that in the end might help sepsis patients in the clinics to survive this devastating disease. Or so that's basically the goal. So we are at the beginning, but I think the prospect that the FIDA technology can have a real or can change the landscape also or has a diagnostic value in the clinics.
Okay, I understand now. Thank you. Wow, that's really impactful research you're doing. Is there anything else that you would want to add? I wonder about the different parameters, because of course there's binding. Are any of the other parameters the kind of quality control or sample characterization that you're using?
So we, of course, when we look at several hundred of patient samples, we also get some odd results that we are not able to interpret right now based on an increased background fluorescence, for example. This is something that we are trying to correlate now with other clinical parameters. We also want to expand this technology for other lipids, not only sphingosine 1-phosphate, but the next step for us is to look at cholesterol binding and transportation, since this is also a very important lipid metabolic, a very important lipid and metabolic pathway, also in sepsis, that has changed quite a bit. And analysis-wise, we are also quite happy because FIDA really requires only very low volumes, particularly when we dilute the samples, the plasma samples, before measurement. We end up using less than 30 microliter of patient samples, while before that we needed at least half a milliliter or even more for repetitive analysis, more than a milliliter of patient samples, which is for human studies quite a bit already. So this also helps a lot.
Okay, wow, wonderful. That's that combined with the speed is seems really impactful for the patients in the end. So that's really nice to hear that there is an improvement. Wonderful. Is there anything else you would like to add?
I think we are very happy with this technique, and I hope that more people will have the option to use it in the future, so that there will be also some confirmations from other labs of the results that we get right now. That would be wonderful.
Thank you, and congratulations on the recent publication. Thank you so much for sharing your opinion. And yes, we will of course add the publication into our literature base, so everybody who's watching it can also just go into literature and access it straight away.
Perfect. Thank you very much.
Thank you.